Good afternoon and all. First of all, I would like to thank Dr. Jay, Dr. Unni and the organizing team for giving me this opportunity to present our work on retinal capillary macroaneurysm. So the earlier term I used to describe this was mini aneurysm. Later on I have changed the term. So this begins with this case. This is a 51-year-old gentleman who presented to us with center involving DME. So as usual, we started the patient with intravitreal anti-VEGF agent. It was bevacizumab initially with poor response. Then we switched over to triamcinolone, again with a minimally slight response, and again we switched over to dexamethasone implant with a poor response. So at the end of 8 months, we could see that the cyst persisted, and we could see that there was a hemorrhage just adjacent to the fovea, which is marked over here, and we could see a shadow over here. When we reviewed his previous scans, what we could note was the presence of these large spaces, which were actually aneurysms, but larger than what we see usually. There was one temporally, and there was one just inferior to fovea. The OCT scan of the other eye also showed similar large aneurysms in the right eye. So coming to one more case, so this is a case of a center involving DME with sensory neural detachment, and in this case also we could see a large aneurysm which was just superior to the fovea, and there was one more which was temporal to the fovea. So in this case he was treated with 3 monthly ranibizumab injections without any response. The SRF remained as it is with the presence of cysts. So with this outset, we planned a retrospective analysis of our patients with treatment-naive DME who presented to us in the last 2 years. So we included only those cases with a good 3D macular OCT centered on the fovea. We excluded those cases with poor quality or the blink artifact or the motion artifact. So what we did was we searched for aneurysms in all the 127 B scans of the 6 into 6 mm the 3D macular OCT. So when we counted them, what we could see was in around 50% of the cases, the largest aneurysm within the 6 mm cube was more than 75 micron, and in around 30% of cases, the largest aneurysm within the 6 mm cube was more than 100 micron. So we can see this is somewhat more than 200 micron. This would be around 100 micron one. This would be around 100 micron. So this is the one which is smaller. So coming to the clinical appearance, what we could note was we could see that there is a white halo around these aneurysms. So we thought it to be a hyalinized aneurysms. But there are other cases in which the white halo, where what we can see over here, is actually thicker when compared to the central red dot. So we thought that there would be some cases in which it would be an exudative material also. So the second thing was is the difference in the response to treatment real? What we saw in those 2 cases, is it real? That we wanted to assess. So for the purpose of the study, we considered aneurysm more than 75 micron in size as a retinal capillary macroaneurysm, because in angiography we could see that they were originating in the capillaries. So we termed it as a macroaneurysm but of capillary origin. So we included only those cases with very good pre and post injection OCT. We included both the cases treated with anti-VEGF and steroids. So then we compared the 2 groups. What we could see was, when compared to the pre-injection CMT and the post-injection CMT, the reduction was statistically significant in all the groups, cases without a capillary macroaneurysm, cases with RCM of more than 75 micron, and RCM more than 100 micron. But when we compared the percentage reduction in CMT, what we could note was the percentage reduction in CMT was just around 20% in cases with RCM more than 100 micron, whereas the mean percentage reduction was around 35% in cases with no RCM, and it was statistically significant. So we considered better we include only more than 100 micron as a significant RCM. So there are so many other biomarkers, so many other factors which are influencing the response to treatment. So one more thing we wanted to see was is the CMT related to this particular aneurysm? So we considered one more parameter, the macular thickness at the site of RCM. So you can see that there are 2 aneurysms, and in this case there is one, and we measured the macular thickness adjacent to this retinal capillary macroaneurysm, and because we considered this as a measure of the RCM related edema. Then we compared it with this reduction in central macular thickness. What we could see was the mean reduction in the macular thickness adjacent to the RCM was significantly lesser when compared to the mean reduction in central macular thickness. So we assumed that the RCM related edema is the one which is responding poorly to pharmacotherapy. So this is a representative example where we can see that the RCM related edema didn't come down significantly, whereas the central macular thickness has become normal post bevacizumab. So what are the other options for treatment in such cases? In a subgroup analysis of our cases, what we could see was steroids had a better reduction in CMT when compared to anti-VEGF, though it was not as good as in those cases without the RCM. And one more thing is like the targeted laser photocoagulation. We targeted these microaneurysms like which were quite away from the fovea. We have only a preliminary result of few cases with follow-up, and it seems to be a better response. For example, the first case which I showed the shadow over here, after good focal laser, like the obliterated lumen is seen with normalization of the foveal contour. And the second case, like after laser to this macroaneurysm, what we could see was there was complete resolution of subretinal fluid, though there is an intraretinal fluid still present with near complete obliteration of the aneurysm. So to summarize, like we considered like aneurysm more than 100 micron in DME as a significant RCM. They were present in close to 30% of treatment naive DME, which is quite a huge number, and they are associated with poor response to pharmacotherapy.